So welcome to today's podcast. I'm Eric Hansen from Brain and Body Health, and today we're talking to Dr. Scott Wustenberg from Optimal Life Chiropractic. Scotty teaches me another couple of tricks that I'm certainly going to be using in my management of chronic pain cases. So in today's podcast, we talk about the difference between centrally sensitized pain versus peripherally sensitized. So with chronic pain, your brain can become really, really good at amplifying pain signals. So sometimes chronic pain is a brain problem, and sometimes it can be your body amplifying the pain, so the pain's getting amplified peripherally. And sometimes it can be both. But Scotty teaches me a way that I'm certainly going to add to my clinical routine on some tests that you can do to figure out, is it central or is it peripheral, because that will help us speed up therapy and give you guys relief as fast as possible. We also talk about some of the sort of metabolic and nutritional impacts that chronic inflammation can have on pain sensitivity, and why it's really important to calm down inflammation if you really want to get rid of your chronic pain. The conversation starts out after I pose Scotty a question about inflammation, and then unfortunately I deleted his initial answer. So then we're getting into the second part of a conversation or question about inflammation. Guys, I hope you enjoy. Look, if you've got any questions at all, email me at eric@brainandbodyhealth.com.au, and otherwise, enjoy.
So the inflammatory reaction that happens from, like, let's just say exercise. So, you're tearing muscle fibers with exercise that creates a localized inflammatory response, lactic acid, blah, blah, blah. That versus significant injury. Like, would you say that if I were eating a crappy diet, I'm going to get post-exercise soreness a lot more often?
The answer to that is yes and no. There's always other factors to it. So one of the main factors to that one is whether you have epigenetics to give you a massive amount of delayed onset muscle soreness. So there are specific codes that will actually determine how you respond to it, how much lactic acid you're going to build up afterwards. So if you're a great repairer, then you're probably not going to get as much. Now that can be balanced out by different epigenetic profiles will have a greater degree of tumor necrosis factor alpha or interleukin-6 production. So some people will have like 70% more inflammation. So no matter what they do, they're going to get more inflammation. Now, they could also have a really good interleukin-10, which will shut it down pretty quickly. They'll still have a higher amount, but they'll get on top of it pretty quick. The other side of that is, though, of course, if you've then got poorer detoxification profiles, or if you've got poorer superoxide dismutase epigenetics, that you're not going to actually create antioxidant enzymes, you can't soak up the abuse you're doing. So from a smaller amount of activity, you might get a really big response, whereas someone with great genetics in the background will do a small amount of activity and they won't really even know that it was occurring. So the food just aggravates that, because food will activate those epigenetics. So, like deep fried chicken or all the possibilities in there, you're going to get a whole lot more oxidative stress coming into the tissue. That's going to set off interleukin-6, interleukin-1 beta, and then going into your shutting it down, interleukin-10. If you've got heightened inflammation, that food's going to give you a bigger impact, and you can't shut it down. So all your sensitized areas are going to show up. And I've got a patient who's also a family member, and he's particularly prone to, going out and having a few bevies with the boys, and, you can't gainsay him from that one. But I keep telling him, look, the pain in your neck that you're getting is because you're inflaming yourself from your habits. It's not a physical thing.
I think one thing that I constantly find with patients is sort of it's hard to get this concept of sensitization across. So patients think that, okay, I've hurt myself, now the pain's gone, or why is it that I did the trivialist of exercises and now my neck's jacked up again? I thought chiropractic was supposed to fix this sort of thing. How dare you not fix me? But then you have to go in and explain, well, no, look, your nervous system is really good at doing what you tell it to do.
Yeah.
So if you're telling it to be sore, then the nociceptive signal starts to get upregulated. Your brain becomes very, very good at sensing pain, and then hey, look, it takes nothing at all to set off a pain reaction.
That's it.
And then we need to keep you pain-free for a fair amount of time for that nerve to stop learning how to be irritated. Like, yeah, that's. Have you got a good way of explaining that?
I love it. That's a brilliant way of explaining it. I think I'll steal that nice suggestion. I talk about the sensitization upregulating parts of the immune system called glial cells, and then I probably run off into too much jargon, but kind of how I learned about it is the more you hit those glial cells to activate both in the brain and the rest of the body, each time they come out, the first time it comes out, especially say you bang your head and you have a mild concussion, first time it comes out of the box, slow to come out, has a look around, then cleans everything up and goes back into its box. Next time it comes out quicker, takes longer to go back in. The more times it comes out, the more it learns to actually come out, because it just assumes that it must be a necessary thing. And by about the 5th or 6th times, it never wants to go back in the box, and it just stays activating inflammation.
Well, as far as TBI and concussion specifically, I was reading I read something, and then I was listening to Brandon Brock talk about it as well, and he was saying that for the initial sort of 10-day from a concussion, you don't want to be doing too much active anti-inflammatory work, because you need that microglial activity to get in there and mop up the damage. And if you inhibit the inflammation too much at that point, then you're just perpetuating the post-concussion syndromes, and you're making things a little bit harder. But surely at a certain point with repeat, so you get that microglial priming where your brain just then becomes more and more irritated that, okay, you've had the 16th head knock over a week process. We need to get you on anti-inflammatories to calm that down. So, like, what's the tipping point for you? Like, at what stage do you say, this is how many head knocks you've had, we need to get anti-inflammatories into you?
I look at it about 5. That's kind of where I saw the notes suggesting.
Days?
So from the amount of time, so that if you've had 5 head knocks, I'll go straight in and start trying to anti-inflame you, because you're going to be so primed already that it's, if we wait, it's just going to keep trying to eat your brain alive. Basically, anything I think after the first week post the injury, you should be starting to look at gentle detoxification. So it doesn't mean that you're going to go in boots and all with lots of antioxidants, but you might be doing things to actually support the liver function, or trying to get some of those other pathways to, while not directly attacking the brain, look at trying to support the whole metabolism so that you can get more energy production, to actually get more neurotransmitters. So maybe putting in a little bit of N-acetylcysteine, or there's a neat new probiotic I've seen that actually generates its own, the bacteria actually generate glutathione. So you could put the bacteria into the gut, and they'll generate the glutathione for you. So you're not actually ramifying the body at all. You're just allowing things to improve.
That's brilliant. Just quickly, that liver boosting formula you put me on has done wonders for shutting down my inflammation. So thanks for that one, mate.
Good. That's excellent news.
Okay, so interesting. So if you it's around that 5th head knock, let's go straight into anti-inflammatory. Is that including? Because I mean, you get patients who've just got that, leaky gut, blood-brain barrier permeability issue, and they may be reconcussing themselves with every, bowl of pasta that they're having. Not realizing that that's causing a concussive event in them.
That's kind of my overall thought on it, is that that's realistically what's probably occurring at that moment in time. The likelihood is that what we've got is these people who are consistently eating their irritants and the reactivity. Say they've got an HLA-DQ2 and they keep having, as you said, a bowl of pasta. It's going to react to the gluten, assuming that they've pre-stressed and pre-primed themselves. And most of these people will have, either by injury, emotional stress, car accidents, And so each time thereafter that they're eating it, their immune system's reacting, it's creating inflammation, it's creating leaking into the bloodstream, and as soon as those activants are getting into the bloodstream, they will hit your brain. There's absolutely crystal clear evidence to show it, but Australian Western medicine doesn't really want to look at it. We keep looking at gluten and allergies as a very gut-based thing, whereas everywhere else in neuroscience has started to look at these foods as being able to get into your brain and make a whole mess of you.
Yeah, big time. Can I pick your brain about sort of pain sensitivity and the importance of controlling blood sugar regulation? So like you're seeing that like your classic diabetic style patient where they've just got really poor blood sugar control, and then you're starting to get pain priming from that.
Sure.
Yeah.
So,
good.
Again, there's a couple of different ways of looking at that. You could have your type 1 versus your type 2 diabetic situation, and both of them will kind of get to the same spot, but kind of from different sort of mechanisms. So again, there's some really good evidence to show that in type 1 diabetics, when the actual introduction of things like gluten into the diet has occurred, will actually set them up for the autoimmune type 1 diabetes. And then the more dysregulated their blood sugar control is, either because they spent long as an undiagnosed type 1 diabetic, or because, as most of them are commonly intended to do, they keep being told that eating whole wheat and lots of grains and regular food is fine. Just keep taking your insulin or get an insulin pump and everything's going to be great. So the issue becomes that the more glucose that's staying in your bloodstream, the more it basically smears all over the actual tissue. And so you'll have heard of the HbA1c test, which is a test that is used to determine how good a blood sugar control a diabetic, whether it's type 1 or type 2, actually has. So it's based upon an autoimmune principle, which is literally that the older the cell is, the more glucose will be smeared on it, and the immune system uses this mechanism to actually determine when it's ready to create apoptosis. So go back 100,000 years, we didn't have much in the way of dietary glucose. So the system was based upon this idea that a cell that was like 100 days old would have a certain amount of these glucose molecules smeared on it in chains. And these are called glycosaminoglycans, and some of them are proteoglycans. So, and then they form reactive glycosaminoglycans, or RAGEs. And so the immune system kind of measures the amount of these chains and goes, well, you're 100 days old, so you must be ready to go. Or depending on which tissue type, it might see that it's 2 years of age, because everything's got a different time period, obviously, to be destroyed. If it gets too old, it risks either breaking down by itself or converting into a cancerous cell. So the immune system in the body is very clever, and it looks at these things and says, you're old enough to kill. Nowadays, though, you can get like a year's worth of sugar in a matter of minutes. So we get this massive influx of glucose going into our peripherals, especially to hands and feet, because they're nice and far away from your organs and your brain. And it spends lots and lots of time there. And this is why it will actively smear onto your tissue and create long chains that the immune system will come along and say, you look like you're 2 years of age, even if you're like 7 weeks, and you're time to die. So we get this upregulation of the inflammatory response, even though it's appropriately programmed. So the response
that's huge.
is normal, but it's not normal all at the same time. So what occurs is you get this constant upregulated damage going on to the cells. Now, this will occur to tissue that's especially metabolically active, like autonomic nerves in the feet. And those autonomic nerves will, of course, regulate the circulation to that distal peripheral tissue, such as the nerves in the feet. And we get cell death, and then we start getting paresthesias going on. Now, one of the fun things is that as soon as your brain stops getting sensory information from, say, your left foot, it's going to start to get distressed, and it'll end up in this thing called TND. And that transneuronal degeneration, I call the last bastion of the damned. And it's this idea that if you're not getting any information coming through, the brain nerve terminator point, the third order neuron, no longer actually has a purpose. Now, it doesn't want to die, so it's going to start reacting and misfiring to try and keep enough protein going to keep itself alive. Now, if it fires off pain, which is meaningful, it keeps itself going. And so the brain will actually generate its own pain to keep its third order neuron alive in the vain hope that you'll actually fix the peripheral tissue to get it connected back up again, because the literature shows that there's at least a 24-month window, and possibly longer, to actually alter the environmental stress at the periphery to keep the nerve actually firing back to the brain. And if you give that person a high enough dose of certain things like methyl B12, active folate, B6, you can actually get the nerve sheath on those peripheral nerves to actually regenerate and settle itself down.
If we're looking at, because, mate, you're testing me. Correct me if I'm wrong. So when we're looking at pain fibers, the C fibers for your pain nociception, do they have a myelin sheath?
Yeah, well, not all of them. Some of them are, well, that's not true. The nerve at the ending doesn't have a sheath, but the actual transmission of the pain does. So these are quite fast-firing nerves. So any of the fast-firing are covered in myelin, and some of the highly myelinated and super fast, and some of them aren't. And the sensory ones, such as going up those posterior columns in the spinothalamic tracts, are very, very fast because they go through the cerebellum, and the cerebellum will use that feedback to actually determine where that foot is, what it's doing. But really fascinatingly, that cerebellar loop actually determines, as I call it, the flavor of suffering going back to the brain. So if the cerebellum is working really well and is kind of in someone who's a very active, fit person, even if they are getting degeneration peripherally, the suffering coming through to the thalamus is actually decreased because the Purkinje fibers actually inhibit a lot of the noise coming through. It's as soon as that person becomes really sedentary and you start getting loss of muscle spindle activity and you lose volume in the cerebellum, you actually get a whole lot more thalamic suffering and connection that way.
Yeah, it's a nasty feedback loop when you're losing proprioceptive traffic from your periphery, and then the cerebellum starts to suffer because of it's just not getting the signals in.
That's it.
And then that's and then I'd imagine so that process that you've just described with the glucose smearing of cells. I remember reading something about, was it that sort of glycosylation or the crystallization of peripheral nerve cells? Is that the term for it? Glucosylation? Say it for me.
Glucosylation?
I haven't had a coffee. Glucosylation. Thank you, mate. Glucosylation for $300. I'd imagine that will happen peripherally as well as centrally.
Absolutely. And so it's absolutely occurring in the peripheral.
Depending on the patency of the blood-brain barrier.
Yep. So, and again, keep in mind, anything that drives systemic inflammation and puts a heightened amount of these cytokines into the bloodstream can and will start stretching holes in the blood-brain barrier. And again, as I bluntly point out to anyone who'll listen, the number one most effective thing that Western diet consumes to do so is alcohol. It instantly opens the blood-brain barrier. You don't need anything else. You don't need the head knock. You don't need nothing. You just need to drink alcohol because it's a solvent.
So you mentioned it briefly. Could you just go over again the supplements that you recommend for controlling that peripheral nervous system cell death from that glucosylation?
So there's quite a few different things that I actually would utilize at that moment in time. From a pain point of view, to try and actually shut down a lot of the peripheral pain and try and inhibit things like biopterin production, we're going to use things that drive nitric oxide, which would include things like arginine. We're going to use S-adenosylmethionine. We might look at doing iron, and that will depend to some degree on what's their blood tests will show up. Magnesium, zinc, phenylalanine, tyrosine, potentially tryptophan, but if the patient's pain is very peripherally mediated and not centrally mediated, then using things like 5-HTP, which is a common supplement to try and make serotonin rise, will actually potentiate more pain in the periphery. So,
what's the mechanism there?
It's literally the 5-HTP will get converted into 5-HT, which is actually serotonin, and it's going to bind to the 5-HT2A and 5-HT3 receptors in the periphery. Now, again, this is kind of one of the interesting things, is that there's a huge amount of serotonin actually manufactured in the periphery, and it doesn't actually cross over into the brain itself. So, and that's kind of one of the things, you see some of these tests that are out there, urinary neurotransmitter tests, they are measuring your peripheral neurotransmitter levels, and they are not accurate to determine what's happening in the brain.
Yeah.
So that's always a great thing for listeners to understand, that it's great to know what your neurotransmitters are doing peripherally, but they're not going to be reflective of what your brain's doing.
Is there a way of, other than sort of questionnaires, measuring central neurotransmitter levels?
Sure, it's called lumbar puncture.
Oh.
Not many
Jesus.
people are jumping up for that one, I'm sure. But if you're at that particular point, having to get that sort of test done, you're not going to be complaining because you're in a bad way anyway. And so, no, there's not a very good way of looking at these things. There is a urinary test which measures a couple of the outputs. But again, it's really much more to do with the end products coming out, not the actual neurotransmitter. And while it is reflective, it's more reflective of, are you detoxifying certain chemicals? And, we're better off kind of looking at what your liver functions are doing, and some really simple things. Most of these things, as it turns out, I think, interestingly enough, are going to be showing up from stuff like activated B6 insufficiency, iron insufficiency. So most of the people with bad levels of serotonin are likely to have issues with things like estrogen dominance. They're likely to be having issues with B6 insufficiency, B12 insufficiency, iron insufficiency. And all of those chemicals are also going to be, or nutrients rather, are going to be affected in someone with dysglycemia and issues with blood sugar control. So other nutrients that would definitely be utilizing would be things like there's this herb called Ervingia, or African mango nut, which is a really neat product that's been used as a food group for a few hundred years or more over in West Africa, and it's shown to downregulate blood sugar and actually get insulin sensitization. It also decreases pain directly. It's shown to decrease appetite, burn mid-body fat. I came across it from a endocrinologist in a lecture from the States, which was quite fascinating. And it works really effectively from that point of view. Obviously, I'd be looking at higher amounts of B12, folate, and again, preferably in their activated versions, whether that's an injectable or otherwise. Getting it past the gut.
Is that, what was it, African mango?
Yep, Ervingia, African mango nut.
Ervingia. Readily available from your sort of vitamin shops? Or is it something that you need to order in specially?
Well, it's one of the things that I carry anyway. It's not...
I find that regulating the dysglycemia is just such a pain in the ass to get under control.
Absolutely.
So if there's a supplement that does it or speeds that process up, that's huge.
It works really effectively as well. And so it's not readily available. Not too many people know about it in Australia, but there is a few places. And the other thing we'd look at is supplements, especially in females at that moment in time, ones with polycystic ovarian syndrome, estrogen dominance, is we'd kind of look at utilizing a estrogen clearing formula like Estrosense or Estroblock, or things that are actually going to try and get the body to detoxify excess estrogens out of the system, because there's a big link between excess estrogen creating insulin insensitivity and more mid-body fat. And the more estrogen imbalance you have and the more fat you put on, those mid-body fat cells actually release inflammatory cytokines like interleukin-6, tumor necrosis factor alpha, which is going to upregulate the amount of inflammation and damage that's going on in your system. And that creates more fat deposition and more estrogen dominance and more dysglycemia, and it just becomes a snowball effect.
I imagine you've come across the what's his name? Hoff. What's the first guy's name? He's the cold guy,
yeah.
cold man, Iceman. With Hoff.
That's it.
Yeah. So like that cold exposure, converting white fat into brown fat, and the sort of effect that has on hormone regulation and clearing out your imbalances. So a neat little plug for your cryo unit there, mate.
Thank you.
If you're worried about that mid belly fat, get some cryotherapy to
That's entirely. It works a treat on that one.
Hey, you're welcome, buddy.
Thank you very much. It's one of the reasons actually that we started getting into getting a cryo unit. It's great for decreasing pain. After I blew my knee apart last year, it was one of the things along with laser therapy that actually got the pain under control. Decreased mid-body fat, maybe look ripped, so I was all over it after that. It's like, it works. I want
some already.
I want one of these. But
just to get back on to before I forget, I want to ask you something about sort of pain. So one of the, again, just talking to patients about that concept of like pain sensitization being both a peripheral and a central thing that goes on. So you're chronically winding up pain fibers in your periphery. Those nerve cells get better at conducting pain signals, so you can get some peripheral nerve sensitization, but then you can also get central nerve sensitization.
Yes.
So because the approach for, I mean, there is some overlap in terms of what we're doing to get rid of pain, both centrally and peripherally. But when you get to that point where this is all centrally, then we need to be doing drastically different things compared to just approaching from a peripheral-only pain control mechanism. So to help differentiate, I mean, I've historically been going mainly off symptomatic findings and how therapy's been progressing. But would a supplement of 5-HTP be useful in that setting? So let's throw a bunch of 5-HTP at you, and if pain starts to escalate, then we say, hey, it's still peripheral, or if pain starts to improve, then we're looking at more of a central mechanism. Check my math on that.
Absolutely what I was trying to get across to the medical doctors a couple of weekends ago when I was lecturing to them. And they looked at me semi-blankly at that moment in time. It just absolutely is a great differentiator, and that also goes for things like using the SSRIs. If you're giving a drug that's going to hold more serotonin in the receptor, you're going to be seeing a significant increase if it's much more peripherally mediated. Now, at this, and so a lot of these people will have a comorbid, say, depressive tendency, because if they're not getting enough serotonin manufactured in the brain for whatever reason, the common approach is to increase that amount of serotonin by using an SSRI or an SNRI or something similar to that, or if they're more natural medicine orientated, using the 5-HTP as a supplement to try and raise the serotonergic levels up. And so what you will see at that moment is if we're sensitizing those 5-HT2A and 5-HT3 receptors in that peripheral tissue, the patient is going to get a lot more allodynia and pain going on in the feet, in the hand, wherever their thing is.
What sort of dosage would you expect to take to have that sort of effect? Is it just take whatever's on the bottle, or would you double or triple or anything like that to have a quicker reaction?
Well, I think they'll probably know it's occurring because they won't
on your average punter.
Yeah, won't be feeling better after the standard doses that we're kind of using. So standard therapeutic dose will probably start exacerbating it, and they're going, well, I'm mentally feeling kind of good, but my pain's getting worse.
Okay.
So.
And then hello, peripheral sensitization at that point of the game.
Correct. And again, what you've got to do is basically, at least temporarily, strip out all that carbohydrate going in. And this is where...
And is it at that, sorry, just about, and at that with that test, would you expect to see, like I'm supplementing with 5-HTP, pain's going to start to escalate at day 1, day 2, week 1, week 2? What sort of time frame on your, again, average punter?
Absolutely, in that first week. Maybe within kind of the first 2 or 3 days, you'll start to see a slight increase. By the end of the week, you're going, I'm not feeling my best.
Okay.
Because what we should be seeing is improvements in potentially sleep mechanisms. We should be seeing improvements in their mood, motivation, etc. But, unfortunately, there's a whole lot of other things in behind serotonergic capacity. And again, the effects of estrogen and estrogen dominant will wipe out so much of your serotonin production that it's kind of hard to differentiate which one's going to be there. But, you've got to look at the fat mass of the patient, I think, before making some of those decisions.
Well, that's going to be a cool test to add to the routine or the regime to help differentiate. Thanks for that, mate. Every time I talk to you, I learn something. That's handy, Scotty. Making the world a better place.
Cool test for you. Not so great for the patient if you're going to be creating more pain in them.
That's an excellent point. First, hey, we're going to try this. If things get worse, then hey, we figured it out. But fingers crossed.
As long as we're open with them, saying, look, we're doing this trial. This is why. This is the possible results. And we've got permission. I see no real problem because it's going to settle pretty quickly as soon as you drop it all out again. But again, in of itself, you're probably going to be looking at their symptoms going, well, look, you've got the dysglycemia, you've got kind of extra saddlebags and mid-body fat. Let's be treating some of that. And the best thing for all of these things, whether it's central or peripheral, is still movement. And if we look at traditional chiropractic and just looking at it from the musculoskeletal management point of view, regardless of its neurophysiological effect, we promote movement of joints and muscle and change. And that is the number one thing in the literature that actually shows decreased pain, either centrally or peripherally. You have to get your patients moving again, because without it, they don't get very far.
Yeah, 100%, mate. Go to get moving.
Yeah.
There was a thing I just thought of to ask you. I wanted to tell you, I've got a funny story for you. I was imagining, patient comes back in and say, hey, I've got more pain. And we're like, that's awesome. We figured it out. I'm glad that you're in here. That's probably not the best. Back when I was sort of going through the midst of my vestibular rehab study, I had a patient come in and, so this is early in the piece. I'm, still getting my head around the textbooks and all that sort of thing. And a patient comes in and says, I've just been diagnosed with Meniere's disease, which is obviously a horrible, horrible thing. So for anyone listening, Meniere's disease, you essentially get horrible vertigo for long periods of time and a bit of hearing loss, and it progressively gets worse and happens in stages. This patient said, hey, Eric, I've got Meniere's disease. And my reaction was to me, that's amazing, wow, because I'd never had a patient with Meniere's disease at that stage of the game. So it was a quick lesson in, hey, Eric, bedside manner, and not everyone is as excited about things like that as you are.
Very sensitive.
Yeah. So, I was sensitive to it. I was just in the wrong way. Negative reaction, not positive reaction. Yeah. Well done. I mean, that says something about my inner workings compared to what should be happening.
Totally understand. I've said kind of similar things to patients. I say, well, look, I find that truly fascinating. It's not a great thing, but I find it fascinating nonetheless.
Yeah. I understand the mechanics of what's going on, and that's, anyway. Mate, I want to pick your brain about something else, but any closing remarks about peripheral or central pain control and what can be done?
Well, again, in both instances, my approach is try and map out whether it is central or peripheral. Both approaches, regardless, you need to be taking out of their system any chemical nutritional irritants. If you keep driving their immune system and therefore with that their adrenal system with stressors, whether it's alcohol or a food or environmental exposure. And this includes things like exposure to inhalant allergens like dust mite allergy or cockroach poop or grasses or mold, etc. If you keep driving that, it doesn't matter how much you kind of use neural wizardry, they're going to feel good for a period of time and then fall backwards because their system is going to go, I've got to fight this forest fire over here. And this is where that very strong integration between the biochemical, physiological point of view as well as the neuro kind of has to fit together. So it's a combined approach no matter what. If they've got a hormonal disturbance, we've got to look at that. Do we need to get in touch with an endocrinologist or otherwise, depending on the severity of it? Because if they required like supplementation of testosterone or whatever to actually help bring it back into a regulated state, the sooner we do that, the more likely we are to have an effect. And people say, well, yeah, but if they've got estrogen dominance because of the dysglycemia, then you just stop the sugar and it'll go away. Well, that's sort of true, but that situation also will knock out the thyroid at that point. So you might actually need supplementation with thyroid hormone to actually bring the whole situation under control because the whole metabolism is so suppressed that you can't eat your way out of the hole.
So that's that art of, okay, you've got all of these things that are affecting it. Let's know which domino do we need to tip before moving on to step 2.
Yeah, because the patient's going to be coming in going, look, I've got pain in my leg, I've got pain in my hands, and we tend to get a bit excited about that. Oh, that's something I've had experience dealing with. And we don't tend to necessarily look at the three-dimensional puzzle of, okay, well, yes, you've got a peripheral disorder, but why do you have that peripheral disorder? If it's caused because you've got Hashimoto's, then the autoimmune causing the Hashimoto's has to be looked at exactly the same time because we do something to fix a hand and you go to sleep at night after having had that sandwich and you're going to get more inflammation as you sleep.
I always find it funny when... because you can't approach any pain, and I'm sure you're going to agree with me, any pain syndrome from a unidirectional response. Like there's always going to be multiple factors going on, like what's the cerebellum doing, what's the peripheral and the central. You've got to put it all together and then layer your therapies so that you're affecting that pain control maximally. And so that might mean you're incorporating, diet and, like you're always going to have multiple things going on. But when, patients always turn up and they go, oh, look, I put my disc out, can you put it back in? And this is just like one crack should do it, right?
Yeah, absolutely.
And you're like, oh yeah, we can do that, buddy. But I'll see you in a week because you've got A, B, C, D through F going on. That's exacerbated. That's. And then the good old people down the road are going, oh yeah, we'll fix that. 2 cracks, it's done.
Yep. And what's worse is that the patient comes to you because they can't get in to see the guy down the road and goes, yeah, but last time I had this, it was 2 cracks and I'm done. What are you talking about, all this other stuff? Yeah, absolutely agree. Had that case on Friday, in fact.
That's a fun one. So, mate, after our talk last week, so we were talking about gluten sensitivity and some of the mechanisms behind how people develop problems from gluten on dairy, and whether it was the herbicides and pesticides that get sprayed into the food groups and the different mechanisms. But you sent me an interesting article straight after that was pretty on point, and it had a term in it that I hadn't come across, and I wanted to ask you to explain it to me because my brain was a little bit fatigued at the time and I couldn't figure it out for myself. What is quorum sensing as far as the have I opened a whole nother 4 hours? Because my understanding of it, quorum sensing is the concept, or it's how your gut bacteria talk to different strains of gut bacteria to know what sort of balance they should be adopting, and that the article you sent me was that the glyphosates and the herbicides, pesticides essentially knocked out that ability to keep regulated between good bacteria, bad bacteria, and the ratios. How does it happen? What is quorum sensing?
Quorum sensing and a quorum is when enough of a certain type of bacteria, or even several types of bacteria, get together and act as if they're a multicellular organism. Okay, so that in itself is a pretty big thing, and I've been looking at it on and off, I don't know, about 7 or so years now. it hasn't really made as much impact into the literature as I think it should do, because I think it's a fairly huge factor that individual bacteria, when they get enough of them, and we'll just say you get 1 versus 10,000, the 10,000 actually acts as if it's a animal like a mouse, for instance. And we're obviously looking at the fact that there's many, many more cells than 10,000 in a mouse or otherwise. But and so the single unit will kind of wobble around and use its flagella and hunt for food. But when you get enough of them together, the whole mass will act for its own benefit and defense. So the whole group will move away from a toxin, and the whole group will move towards food, or they might work en masse to attack something. And so they actively have this group unity, which is called the quorum. And what's shown is that the things like the glyphosates will knock out some of the quorum sensing, but that's some of the quorum sensing for bacteria that actually get destroyed by things like the glyphosates, and some of them don't. And that's the problem, because you can actually lose a lot of your good guys, which are a whole lot more fragile, and be left with quorums of bacteria that you really don't want running the show in there, that are going to upregulate your behavior to hunt for things like sugars, carbs, soft drink. They can cause foggy headedness, etc. So the issue is that if you have the quorum out of balance, not in a symbiotic, healthy relationship to you, because what the bacteria are meant to be doing is keeping you working and you keep them working. And so you're basically trying to feed your bacteria positive things to make them have a good day, so they will release energy and nutrients like B12 and folate and coenzyme Q10 and tryptophan, so that you stay working properly.
That's cool. So yeah, essentially quorum sensing is a lot like neuroplasticity. It's not just a good thing, or it can be a bad thing.
It certainly can be a bad thing, but again, up until the last kind of few years, maybe this last decade, we didn't even know that bacteria could act en masse as a multicellular organism, and it really hasn't, as I said, made a lot of impact. But glyphosates are really not very good for the gut bacteria, let alone the gut lining.
Is there any research, or if it hasn't made much of a splash, I'd imagine not, in the sort of mechanism behind quorum sensing?
I don't know. I certainly haven't seen a whole lot of it. The last thing I saw was a video actually watching it occur, and it's the most fascinatingly creepy thing I've ever seen.
That's cool.
Yeah. But no, they don't really. It's suggested that it's some degree of secretion of chemicals, but there's very little absolute knowledge known about it that I'm aware of.
And the other thing that we got tagged in that I wanted to pick your brain about was the what was it? There was that's right. The trigger for autoimmune disease being possibly a viral.
Oh yes.
Yeah, so that's a viral etiology for autoimmune disease.
Well, there's a whole bunch of stuff. So if you look at there's groups out there called that research PANs and PANDAS. So there's a whole lot of information suggesting that both virology and bacteria can actually produce disturbances. My daughter, unfortunately, has a case of PANS, and every now and again it blows up on us. So she has never shown an outward display of a strep infection. However, currently we're dealing with her having high strep A titers in her bloodstream. So she's got these high levels of antibodies, and they cause brain fog and inability to think straight. And there's suggestions, again, along the same line, that locked-in syndrome comes from the same thing. Dystonia. So there's this wonderful researcher out of, I think, Harvard, called Professor or Dr. Cunningham, and they've developed an autoimmune panel called the Cunningham panel that actually looks at things like strep and other virologies as well for their effect on neurochemical tissue, and trying to determine, do you have this particular situation and disease. Now, schizophrenia is suggested as a possible effect from both viruses. So there's huge amounts of stuff on it.
That's going to be an exciting to watch that research unfold over the next couple of years.
Well, the problem is this particular area has been around for a while. I found a paper listed in 1992. Okay, so this is not new information. What the problem is that, and as far as I can see, is that we don't have any new antibiotic drugs coming on that actually are worth tinker's damn. They keep failing, and the bacteria are getting around it because we gave them out like candy. And two, realistically, there's a bucket load of money to be made from pharmaceuticals that actually treat, whether they do or don't, mental illness. And so we're not really looking for causative, we're looking at maintaining and the maintenance of symptoms at this moment in time. So, I see some conflicts of interest in medical science, because if we look at it and found that it actually was a virus and we gave IVIG, or we gave, an antibiotic, and we knocked out the problem at the beginning, we actually stop a lot of the ongoing therapization and treatment of the conditions, and therefore people lose lots and lots of money.
You're not suggesting that Big Pharma is interested in keeping you as a pill-popping junkie for the rest of your life? Is that?
I'm not suggesting that, because that would be inappropriate, because I have no evidence of it. But I do think that there is not enough credence paid to looking for the cause of these things, especially when the evidence is quite strong. Like strep pans is well documented, where people have complete remission from it and live a normal life afterwards when they get the appropriate treatment. When I treated my daughter with antibiotics, her brain made enormous turnarounds. So, I'm all over that one. But it's not commonly looked at. When I was speaking to a GP who I'm getting help with, she's looking at me like I was mad. That's a bit controversial. And the results have come back and I'm right. And so I'm waiting to hear what her opinion on my controversy is.
Well, let's fingers crossed for a more open-minded field in the not too distant future, for the sake of
everyone.
Well, yeah, for the sake of everyone. Mate, this is awesome. I think we've chatted about everything that I had on the agenda.
Excellent.
Did you have any closing remarks?
Don't get bacteria up your nose. Wash your hands regularly, and don't chew your fingernails, as you'll get threadworm otherwise. Grinding teeth is a classic hallmark sign, as is picking your own skin for parasitic infection.
Really?
Yeah. So,
grinding your teeth. Okay.
Nighttime grinding. Now there is mechanical things that activate it as well, but like toddlers grinding their teeth, that sort of thing, and they flatten their teeth out, has a really high incidence association with parasitic infections. And again, usually those kids will have issues along the strep, staph, clostridia, viral sorts of pathways.
Okay, so teeth grinding and skin picking. Let's get some parasite checking happening.
Does pay too.
Poo in a bottle and see what comes out. Nice,
okay,
mate. Yeah, good chat as always. Yeah, mate. Let's wrap it up.
Trouble.
That's we're done. All right.
Talk to you
guys.
next week.
Nice one, guys. I hope you learned a lot. I certainly did. That was a great conversation about pain and a few other bits and pieces. If you've got any questions at all for Dr. Scott Wustenberg, feel free to call him on 0733710222, and that's Optimal Life Chiropractic if you want to Google that one. Or if you've got questions for me, you can Google Brain and Body Health, or give me a call on 9817-6611 with the area code 02, or you can reach me through email, eric@brainandbodyhealth.com.au. But otherwise, guys, stay tuned for the next one. All right, enjoy.
Thank you for watching. To learn more from Dr. Scott, visit our site at optihuman.com.au.